We know that adolescents, teens make up a quarter to a third of our practices, which is why we're bringing to bear a lot of focus on adolescent and young adult health, much of which has been highlighted over these last couple of years with the pandemic and all these other social issues that have sort of been bubbling up. Our next presentation is from two other members of our adolescent and young adult faculty, Drs. Waters and D'Angelo, and it's caring for trans and gender diverse youth in the primary care setting. I got that right.
Thank you, Mark, and greetings to the many people I know. This is a big time for me. I am celebrating next week my 40th year at Children's National. So, and it also coincides with my birthday, which I'm not going to tell you how old I am. But anyway, it's wonderful to be here, and these are very difficult topics that we're going to be discussing today, because I know that for many of you in your practices, you hadn't seen patients who are gender diverse until very recently. That's certainly true for our practices relatively as well. But regardless, my real job today is to first of all tell you that we have no specific disclosures. And secondly, to introduce our third-year fellow in adolescent and young adult medicine, Dr. Joseph Waters. Dr. Waters will not be our third-year fellow as of tomorrow when he has his formal graduation, but he will then be our partner and co-faculty member in the Division of Adolescent and Young Adult Medicine. So. Joe's worked with us over the past 3 years and has done extraordinary work, particularly in this area that we're going to be talking about today. Without further ado, Dr. Waters.
Thank you, Dr. D'Angelo. So these are the learning objectives. For the sake of time, I won't go through them, but yeah, in the spirit of June being Pride Month, you may hear a lot of variations on the acronym LGBT, LGBTQIA+++, but we're really going to be talking about one specific subset of this acronym, which revolves around one's gender identity. And I know that each of us comes to this talk with a different level of foundational knowledge about what gender identity means, but I want to be sure we're sort of all on the same foundation as it relates to these four concepts, which are your sex assigned at birth, gender identity, gender expression, and your gender perception. So the first of these is your sex assigned at birth. And this really is sometimes referred to as the birth sex or the natal sex, biological sex, but the most appropriate terminology really is sex assigned at birth or sex designated at birth. And this really is a complex interplay of anatomical, hormonal, and chromosomal makeups. And for traditional sense, it was thought that two X's equal a female and XY equals a male, but we know that there's a lot of complexity to that. And that sort of knowledge or that understanding really is our misunderstanding of the interplay between biology, social constructs, and anatomy. And my hope is that we reconstruct our language and start using sex assigned at birth more as a way of recognizing that that decision really was not made by the individual, but that it was made by someone else, and that the assignment of male or female cannot fully capture the variety or interplay of those concepts. And we even know that this designation of M or F on the birth certificate has some ambiguity as well. And in fact, in 23 states, including the federal government, allows for a third or a non-binary gender marker on identification documents. The next foundational concept that we'll talk about is one's gender identity, which is really a person's inner sense of being. And we know that there are an array of gender identities. And to many people, it's important that they find a label with which they identify. But for others who may not feel that way, they don't feel the need to strictly identify themselves solely based on their gender. Gender identity is something that all children should be screened, or their identity should be assessed based on their developmental stage of life. And we know that research substantiates that children who assert their gender identity as trans or on the gender diverse spectrum can insistently and consistently assert this identity just as their developmentally equal peers who identify as cisgender. And those youth benefit from the same level of social acceptance and affirmation that their cisgender peers are getting. Oh, sorry, I forgot to take off my mask. We know that there are variations in gender identity and expression, and this is a dynamic process. And this dynamic process really underscores the aspects of diversity in human development. And we know that it may not necessarily reflect the binary definition that we typically see, but we know it's more along the spectrum, where man and woman may be on each side, but there's also room for people who have fluidity in their gender or people who don't identify as a singular gender at all. The third and really final concept we're going to talk about is gender expression. And we know that gender expression really is the way a person communicates their gender to the outside world through their mannerisms, how they speak, the clothes they choose to wear, the behaviors in which they carry themselves. But we know really that gender is a social construct that's largely influenced by society and culture, the context in which a person's presenting themselves, the historical period. Being someone who lives in Washington, I don't think would be very common or accepted now for many people to walk around in wigs and makeup and heels if they're a particular gender. But there was a point in time where in Washington, D.C., that was very well accepted. Often one's gender role doesn't really center around a person's body parts, their anatomy, but more so on the less tangible aspects of who they are. So what really does it mean to be transgender or cisgender? So we typically think of being cisgender as having a congruence between one's sex assigned at birth and one's gender identity. And in the most superficial sense, trans refers to an incongruence between one's gender identity and their sex assigned at birth. But really, transgender is an umbrella term that encompasses a lot of different identities in which someone experiences an incongruence between the sex they are assigned at birth and how they feel about themselves. And it's important to know that some trans people may not identify themselves as transgender specifically, but may use one of these other definitions, such as non-binary, genderqueer, gender fluid, or even agender or not identifying with a singular gender at all. So, when we talk about this population of people, there are we could easily make this lecture of healthcare statistics about different health disparities, but I want to really shift how we think about health disparities in this population and really understand, based on the science and data that we know now, if you go back and look at the original position statements from the American Academy of Pediatrics and the American Psychiatric and Psychological Associations, they underscore that being a member of the LGBTQ plus community is not inherently a problem or a risk behavior that leads to negative mental health outcomes. Rather, it's actually the combination of negative health outcomes that these youth experience from compounding prejudice and discrimination that leads to adverse coping mechanisms that lead to poor health outcomes. But when you think about a strengths-based model in caring for these youth, it really posits that personal and collective strengths of minority populations and the ways in which those population strengths are embraced and cultivated lead to increased resiliency and therefore more positive mental and physical health outcomes. But that improvement in their health outcomes really is contingent on providing support and preventing that increased minority stress, which can have a compounding interest for those youth. So as a gender care specialist or someone who's providing care for these youth, what do we specifically do? And it really centers around what we call gender affirming care, which is a developmentally appropriate framework of care that's directed towards acceptance and appreciation of an individual's gender experience. And that care is provided in a nurturing, non-judgmental, and trauma-informed approach. And it's really made of these four main modalities broken up into four categories of social affirmation, medical affirmation, surgical affirmation, and legal affirmation. And we typically use the words affirmation or gender journey rather than transitioning, because transitioning really refers to or gives the notion that someone is transitioning to another person. But affirmation or discussing how one's going about their gender journey really shows that that person is coming into their inner sense of being and developing more into themselves and not transitioning to someone else. And this approach really focuses on not worrying about who the child will become, but valuing each individual for who they are, and even at a young age, fostering secure attachment and building resilience for those people. So I won't dawdle on each one of the aspects of care, but just to briefly mention that social affirmation can be anything from using their chosen name and pronouns, modifying the way that they present themselves through their clothing or non-permanent body modifiers. Legal affirmation really pertains to addressing their name and gender marker on legal documentation, such as their driver's license or their birth certificate. Medical affirmation really has to do with starting medications to affirm their gender identity through starting puberty blockers or testosterone or estrogen medications, some type of androgen blockade to increase the efficacy of their estrogen, or birth control, whether it be for contraception or menstrual suppressive needs. And then finally, surgical affirmation, which has a variety of surgical procedures that can be done to help each individual feel most themselves. But really the purpose of this talk is, what can you as primary care providers do in your office or in your settings to affirm your gender diverse patient's identity? And it really is a combination of these 6 things. So we'll go through each of them individually. The first is creating an inclusive and safe clinical space. Upon entering a healthcare facility or an office, the clinical setting can be a preview of the type of environment that a patient's going to encounter throughout their clinical session. And patients and families look for signs or clues of diversity and openness to persons of an LGBTQIA identity. So what I would charge you to do is assess the physical environment of your building or your office setting with attention to what type of message you may be communicating to patients and families. Think, what does your environment say about who you are or the health services that you recognize and offer for patients? And these can be done through a variety of different ways, whether it's posting pictures that reflect your patient population, having rainbow decals or safe space stickers, wearing buttons or pronoun pins on your lanyards, etc. The next thing that you can do as a primary care provider is using affirming language to affirm a patient's gender identity. And really, using gender affirming language can be one of the most profound ways in which you can affirm a patient's identity. This can be done by respectfully using a person's pronouns and chosen name. And we used to use preferred name and preferred pronouns as the language that we use to suggest this, but we're moving away from using preferred because it suggests that it's optional and that using it necessarily isn't dictated. And understanding that we're not legally obligated to address patients by what's on their ID or what's reflected in the medical record, and that we should be using a patient's name that they are asserting to be the one that most aligns with their identity, and understanding that this can change over time. So this visit, your patient may want to be called Susie, and next visit, they may want to be called Mary, and knowing that they may be adjusting to different names and pronouns based on where they are in their transition in their journey. And then it's important to practice handoff communication with ancillary staff or nurses to prevent patients from constantly having to repeat themselves or run the risk of being misgendered or dead named throughout the process. And another concept that's really important, and I really underscore this as an adolescent medicine physician, which is ensuring confidentiality, that the information that the patient shares with you will remain between the patient and the provider. And whether this involves using a different name with family members present or a different name in different settings, it's important to have an open conversation with these youth about where they are on their gender journey, how out they are, and in what context they're out, so that where they feel open in sharing that information with you, and then in what settings you should use the appropriate information. And then check in with the patient often about their affirmed name and pronouns, and encourage them to let you know that if that changes in future encounters, you can reflect that. And I think another important conversation to have is asking the teen what they feel comfortable being documented in the medical record. They may just initially be exploring their gender identity and may not yet be ready for something to be carried in the chart that then runs risk of being perpetuated at future visits. The next thing that we can work on is our intake forms. Intake forms, I think, are notorious for having a very heteronormative, cisgendered bias in the way that we present the information. And I actually pulled these two examples from our gender clinic forms, but really having a space or fill-in option for patients to express their sex assigned at birth, their gender identity, having a name, or a place for them to put their name, that they want to be addressed at each visit, and a place for their pronouns. It's also really important for us not to assume that the guardians or the parents that are accompanying patients are mother and father, and that we just ask strictly who is parent one, who's parent two, and then reframing marital status as relationship status using gender inclusive responses such as partner or spouse. And then I think it's really important to continue to have staff training. Training is essential not only for administrators and clinical providers, but also for all of the non-clinical staff or anyone who's going to have patient contact, such as outreach workers, registration workers, front desk staff, billing and insurance staff, or even the security personnel. And avoid the notion of competence. Growth in staff training is dynamic, and having an open forum for feedback on how things are going, where processes can be improved, and allowing time for reflection can create the most inclusive and diverse environment. And then I would also say, don't be afraid to be an upstanding bystander. If you see someone using language or doing something that's not affirming for your patient, even if the patient's not present, it's our responsibility to uphold that affirmation, even in those settings. And then lastly, understanding that treatment planning should be patient-centric. I often use the analogy that the patient is the driver of the bus, but we are merely just riding. And it's up to us to help facilitate discussions, but we shouldn't be leading the agenda. We should be providing supportive discussions about key important factors that may play into their treatment plan, but allowing the patient to really drive what their goals are. And as long as it's developmentally appropriate and safe, we should allow that to happen in conjunction and conversations with the family and the patient. And then lastly, just owning we aren't perfect. Patients understand that we're humans. And if you make a mistake, the most appropriate thing really is to correct it, apologize, and move on. You don't want to overly compensate and apologize, because then it brings the emotional onus on you instead of the patient to own that mistake. And then be prepared to troubleshoot with staff members and amongst yourselves, and to avoid further issues of embarrassing or outing the patient. But what do we not want to do? First and foremost, you don't really want to interview any teen with the parent in the room, only with the parent in the room. Give teens an opportunity to talk with you confidentially and privately about what may be going on in their life. Don't assume someone's name or pronouns or gender based on what you see in the medical record. And don't automatically assume that gender identity or expression dictates behaviors or how one will present themselves. We shouldn't be dismissive of families or patients and assess this as just a phase or something that they're going through, but really support them in their developmental stage of life. And then I think it's very clear to us all, but we shouldn't imply, suggest, or refer any patient for reparative therapy or conversion therapy, as we know that that's very psychologically damaging. So is there an ongoing role for primary providers in caring for transgender youth? The overwhelming answer is absolutely yes. You can help treat significant dysphoria by referring to mental health for any underlying mental health needs. You can start menstrual suppressive agents if that's really what their main driving factor of dysphoria is, and then also support them in their social transition. Managing sexual health issues is a big component of what we do as adolescent medicine providers and as primary care providers. There's certainly a role for STI screening and prevention, contraceptive needs, screening for HIV, putting them on PrEP if needed, and then monitoring medical consequences once they start gender affirming hormones. Whether it be checking cholesterol, watching for hemoconcentration, surveying for any type of thromboembolic complications. And then also it's really important to continue to assess and screen for safety in their home, in their school, and their community setting as they go through their gender journey. So the take-home points, which reflect back to our learning objectives, which is the primary care setting really is a place to provide gender-affirming care. Pediatricians should support healthy gender identity development as part of normal anticipatory guidance and screening. And if anyone has any incongruence in their gender identity and their sex assigned at birth, they can then have more detailed screening or referral to a gender clinic. Children should feel affirmed in their gender identity throughout their developmental build and build significant children who are affirmed in their gender identity throughout development build significant resilience and thrive into healthy, happy adults, just as any cisgendered patient would. And then we as pediatricians should remain supportive. And in the words of Bernard Dreyer, we really shouldn't be our first patient's bully. I'll turn it over to Dr. D'Angelo to talk a little bit about what is primary care providers, where we can refer these patients.
Terrific. Thank you, Joe. I'm delighted that you're going to be part of our team. Okay. I know that many of you who have tried to negotiate the system of finding the appropriate referral at Children's are sometimes overcome. And certainly with regard to gender care services, we have evolved over the course of the past 8 years, a really tight working relationship between the 5 clinics at Children's that do provide gender affirming care. These clinics include the Youth Pride Clinic, which is centered in adolescent and young adult medicine, the Gender Development Program, which is centered in the Department of Psychiatry and usually addresses initially the needs of younger children who are experiencing gender incongruence. We have a very specialized program that is internationally known, and it's probably the #1 expert in the world on gender and autism, John Strang's clinic at Children's in the Department of Neuropsychology. Endocrinology is usually and always an active part of our team. They have their own clinic for people who are already well affirmed in their identity and who are really just looking to begin medical treatment. And Dr. Rebecca Persky runs that clinic. And finally, pediatric and adolescent gynecology for years has provided specialty care to gender incongruent youth, and particularly with regard to menstrual suppression, but also with regard to long-term puberty delay in the form of implantable gonadotropin agonists. So is there an easy way through this morass of our 5 clinics? I can assure you that our 5 clinics talk regularly. We meet either every week or every other week, representatives from all our group. And we do sponsor a multidisciplinary clinic where all of our clinics are represented for youth who may be just entering our system or families who are in particular need of a more immediate consultation. The easiest way is to come in through our gender care services and patient navigation system. Shane Hanais has been our patient navigator for about the past 18 months. He's uniquely qualified. He's in terms of his background and in terms of his knowledge to help providers and families negotiate our system. There are separate phone numbers for each of our individual clinics. And I would be remiss if I didn't tell you just a little bit about our clinic. That is the Youth Pride Clinic, which we began in 2015. And I think that the creation of the Youth Pride Clinic, we actually were able to consolidate services throughout the institution, getting the 4 other clinics to work more closely together than they ever have before. And we provide both medical and gender affirming primary care, menstrual suppression, and gender affirming hormones if and when people reach that part of their gender journey. Gender therapy that provides brief gender-focused therapy and aimed at exploring and assessing gender needs is also provided through the Youth Pride Clinic. Youth with more in-depth needs can be seen and evaluated in the Gender Development Clinic. And finally, our medical providers include myself, Dr. Tanya Ketcher, Dr. Brooke Boker, and of course, Dr. Waters, and our nurse practitioner, Amy Klamberg, and our new gender therapist who is just coming on board in September is Dr. Molly Bash. So we are delighted to be able to provide services to you and your patients. And as I said, a warm welcome to Dr. Waters.
Any time, we have resources that you can view in the PowerPoint slide.
Yeah, no,
Questions?
it's great. There's a question. You are the powerhouse in adolescent and young adult medicine. There's a question that came in on our chat about if there are younger children expressing gender identity questions or concerns, what are the resources for younger children?
The younger children usually end up being referred through the Gender Development Clinic. And Shane can be very helpful in that, because if there are specific needs that need to be addressed earlier on, we can make sure that those needs get addressed. I say that because the traditional, for someone who just comes in to make an appointment in gender development, there is a waiting time. But we have plenty of ways around those hurdles.
Yes, I was just wondering if you could speak to the laws regarding consent for adolescents in the district who are seeking hormonal treatment for gender identity.
Right. We are very fortunate to practice in the District of Columbia because we can provide full consent as of the 13th birthday for any youth seeking services for sexually transmitted disease, pregnancy, mental health issues in particular, and substance abuse. Now, obviously, we do not do that if there is any implication that the adolescent is at risk to themselves or to other individuals. And so issues, for instance, of severe substance disorder are things that usually we insist and need to be, parents need to be involved.
Just an administrative issue. Actually, it came up this week in my own office on naming. Submitting prescriptions or referrals becomes a problem that I don't know how to handle because if you start changing that, their insurance coverage starts disappearing.
Yeah.
How do you handle that?
It's actually quite difficult, and we address it up front. Because during the course of treatment, many of our patients do indeed change their name. And, we tell them this is a multi-step process. You have to change your name first in your state of residence. Then you have to change your name with the insurance company. And then when you've done that, we will change your name in the medical record at Children's National. But we cannot do that until those other two steps have been accomplished, or we can't write prescriptions for the patients. So you're right, this is a dilemma. And I think that the very best way to address that is right up front, saying, you must realize, although we respect your gender affirmation, we need to at times use your previous name for legal purposes.